is really any pre-surgical patient with EBMD that requires epithelial removal should have a PROKERA. Any patient with severe dry eye disease where they have central SPK or filaments really needs to have a PROKERA. And you can do this in your practice. We do this in our practice routinely, and we do keratectomies along with PROKERA for patients with EBMD. This is an example. This is not a really unique case, and I picked this intentionally because this should be routine. The cases we saw earlier are not routine cases. We're all comfortable on the panel managing them, but a lot of these patients are going to be co-managed with the cornea specialist. This is a routine case that you should be identifying in your practice. Maybe you're not the one to do the corneal scrape and do the keratectomy, but you should at least identify this patient has visually significant EBMD. So when they come to the surgeon, they're prepared for what they need to do to have a great outcome. This patient was referred to our practice, has EBMD, left eye greater than right, and the patient's interested in a multifocal IOL. Years ago, we may say, you know, Mrs. Smith, you really can't have that. Your cornea is not conducive to having that type of technology. We're going to put you in a standard lens. We don't do that anymore. And when we do a procedure like a prokeratectomy, where we do an SK followed by a PROKERA placement, we're doing this so that this patient can have an advanced technology IOL. So they have that opportunity to have this great visual benefit for the rest of their life. And I think we need to not allow our patients to have anything but the best. And I think that we really need to optimize the surface prior to surgery to do that. And it used to be that in our practice, we would do a keratectomy in the lane and maybe just use a BCL. We know that healing is going to be much better, longer, better term outcome with patients with a PROKERA after they've had that superficial keratectomy. So in our practice, this patient, you can see on their axial topography, has some irregular astigmatism. They have an SK, they have a PROKERA placed that day. We have them come back in 4 or 5 days. They're on an antibiotic drop, sometimes a steroid as well. We're going to remove that PROKERA about day 4 or 5. The epithelium is going to be intact. And then we're going to want to see them back in 3 or 4 weeks after that to repeat their measurements. And you can see the vast difference here. This patient was seen on October the 5th. They have significant amounts of irregular astigmatism, especially nasally. And you can see both the axis and the magnitude of their astigmatism was changed after doing this superficial keratectomy with the PROKERA. So what are we doing here? We're allowing this patient to now have a multifocal IOL, probably a toric multifocal IOL, and we are going to have a much better chance of them having the vision that they deserve after their surgery. This is so prevalent, this is so common, and this really needs to be a focus, in addition to dry eye and neurotrophic keratopathy, certainly. But preoperative optimization of the ocular surface is in every OD's wheelhouse. We need to identify these patients. If you're comfortable doing these things in your practice, great. If not, make sure you let the patient know what they're going to potentially need to do to have the outcome that they want with their refractive cataract surgery.